Hello and welcome to Single Payer Radio. I'm Paul Hoppe, broadcasting from the Hayburn Building in Louisville on the WFMP 106.5 Forward Radio Community Network. Our programs air every Monday at 2 p.m., Tuesday at 7 a.m., and Wednesday at 11 a.m. And we also stream our show on SoundCloud. The show is a project of Kentuckians for Single Payer Healthcare in conjunction with Physicians for a National Health Program through its Kentucky chapter. We produce this program because we believe healthcare is a human right. We advocate for a national, not-for-profit, publicly funded, single-payer healthcare system that works for everyone. The views and opinions expressed on our show are those of the speakers and not the station. Our station relies on volunteers like myself and your ideas and donations to keep us on the air. Today, Doctors Mike Flynn and Jean Shively join me as co-hosts, and our topic is today navigating the jungle known as Medicaid. So let's jump right in. Dr. Flynn?
Yeah, this is Michael Flynn, a retired surgical oncologist from the University of Louisville. Let me begin with the usual disclaimer that any comments I make during this program represent my personal views and do not represent the views of the Department of Surgery or the University of Louisville. Now, as Paul said, our topic today is Medicaid, which is a medical insurance program for underserved population in this country, which is under siege right now by the ideological geniuses in the United States Congress. We have two special guests today, which I will introduce in just a moment. Dr. Barbara Casper and Amber. They both have experience with Medicaid from a somewhat different perspective. Before introducing Dr. Casper, I just would like to make a challenge to our listeners. We've done this in the past. We will talk about a lot of issues, and I would suggest to our listeners that there are multiple ways that they can double check the facts or the comments that we make to determine how their veracity or truthfulness. The Journal of American Medical Association, New England Journal of Medicine, Wikipedia. You can just get on Google and go to Medicaid, and there's a ton of places you can go to get information. I want to give the listeners one option. There's an article published in the New England Journal of Medicine on the 26th of February of this year. It's written by a lawyer, and it is entitled Medicaid on the Chopping Block, and it addresses all of the issues that may be the consequences of the congressional approach to use or partly defund Medicaid in order to extend the first Trump administration tax cuts for the rich. Just one comment about that, and I will move on. 50% of the benefit of the initial tax cuts from the first Trump administration went to the top 5% of this country. The remaining 95% of the country got whatever benefit they might have gotten from this supposed tax cut. So let me begin with introducing one of our guests, Dr. Barbara Casper, as a retired internist. She got her medical degree from the University of Tennessee College of Medicine, did a medical residency at the Erlanger Medical Center Baroness campus. She joined the U of L faculty in the medical department in 1998 and spent most of her career treating the underserved population and Medicaid recipients. Dr. Casper, when it's your turn to make your comments, if I've not said everything correctly, you'll have an opportunity to correct it. Gene, you want to introduce our other guest?
Yes, sir. I'm Eugene Shively. I'm a retired rural surgeon from Campbellsville, Kentucky. What I say is that it's my opinion, not that of Taylor Regional Hospital, nor the Department of Surgery at the University of Louisville. I think we have an extremely interesting topic today, and it's very timely since it may be on the chopping block and could have extreme, devastating effect on Kentucky. Medicaid money coming from the federal government is more than the entire budget of the state of Kentucky, and there's been a proposal that I've discussed with one of our legislatures in the Senate that the federal government, if they cut Medicaid back 5%, the state could not deal with that in their budget, so we would be talking about cutting back on Medicaid, which would be devastating. In my congressional district, which is the first congressional district, it would be interesting for your viewers to look at the map of the first congressional district. It goes all the way from Paducah along the Tennessee border, including Bowling Green up through Taylor County and all the way to Frankfort. It looks like a piece of a puzzle. It's quite interesting, and it would be interesting to know why that's like that. Our guest, one of our guests today is Amber. She is a member of our organization, and she's had a lot of experience with Medicaid, and she's going to tell us about her experience with Medicaid, and hope you'll get some idea of the problems that we have with Medicaid.
All right, so let's begin. Amber, we're going to let you go first. You can make whatever comments you'd like to make about your Medicaid experience for as long as you'd like, and then we'll let Dr. Casper, and then we'll move on with the conversation.
Okay, thank you. I just want to say that my experience with Medicaid has been extremely positive. In fact, I would credit Medicaid with saving my life at this point. For many years, I had somewhat kind of stop and go exposure to the medical community, even though about 15 years ago, I had a complete thyroidectomy. There were many weeks and months that I would go with either parsing my medications or not taking them at all, which has probably led to some of the long-term side effects that I have now regarding heart failure and some other conditions. Being on Medicaid these past 4 years has actually put me in a position where I'm receiving constant care and consistent care, most importantly. And that has made it so that my health, although it's not going to ever recover completely, at least it's stabilized and not continuing to deteriorate. And I can't express to people how many people will be negatively impacted and how many deaths will probably result if they did actually do something like cut Medicaid.
Okay, Amber, thank you very much. Barbara, your turn. You can give us an idea of what your experience has been from the standpoint of a provider.
Well, thank you very much for inviting me to discuss this. This is something that's very important and I think is likely to impact a lot of people in the state of Kentucky in particular. So I had the opportunity to treat patients who were underinsured and uninsured for all of my career, and moved here in 1998 prior to the expansion of Medicaid through the ACA. And at that point, it was just so difficult to care for patients. Over half of the patients I saw at U of L clinics, and by the way, this, I would also have a disclaimer, these are only my opinions and not at all related to University of Louisville, but over half of our patients were uninsured, and so trying to navigate getting them appropriate care in that setting was just extremely difficult, and many of our patients went without. I could give you tons of stories of people who came to care late because they were afraid of the financial consequences of interactions with the medical care system and died unnecessarily. So when the ACA was implemented and Medicaid was expanded, it was just night and day for my patients. I had one patient who came to see me who was in his early 50s and had had a heart attack and had hypertension and not diabetes, but a high cholesterol, and smoked, and none of that was ever controlled. And after the Medicaid expansion, when I saw him, he came in and admitted that he had just not been able to afford his medicines. And he looked at me and says, "Doc, I'm going to take my medicines now. I have insurance for the first time in my life." And it made me actually quite emotional. I had to leave the room because it made me really sad that this man had suffered without it. So I'm very concerned about what will happen to our patients. As it is now, only about 5% of Kentuckians are uninsured in this state because our governor, Steve Beshear, opted to expand Medicaid. Most of the southern states did not. And so, and there are about 1.5 million people in Kentucky who currently are on Medicaid. So this is a catastrophe looming if that is cut.
Thank you, Barbara. Jean, do you want to begin the conversation?
Amber, could you tell us what the requirements are to be on Medicaid?
Yes. So essentially, it's based on the poverty level. So they look at the overall household income as well as your assets. And at that point, they actually, sorry about that, they look at those numbers. So in Kentucky, the numbers are actually posted on the government website. I think that you may have that information. But for my own case, I have no current income and no assets because of some things that happened in my past. And so that has allowed me to qualify. You have to be 64 or younger. At 65, I believe that they switch you to Medicare, but they do have a paid version of that for people that fall below the poverty line. So.
Yeah, I do have those numbers if it's pertinent to the conversation, if people want to know.
Yeah, please go ahead.
Go ahead and give us the numbers.
Okay, so for people from ages 19 to 64, it's up to 138% of the federal poverty level, which translates for a single person is $20,120 per year. For a family of three, it's $35,000. So just for context, if you worked 40 hours in a minimum wage job, which is $7.25 in Kentucky, and you worked 40 hours a week, 52 weeks a year, your income would be $15,080. So pretty much any person working full-time at a minimum wage job as a single person would qualify for Medicaid, which is pretty telling, actually. So for pregnant women, you can have up to 200% of the federal poverty level, and that is $30,000 for a single person and $62,400 for up to 4 people in a family. So they recognize that it really pays to take care of pregnant women to make sure they have a good birth. So and then also, Amber was correct that you have to be 19 to 64, but there is a children's program as well. So, and if you make a little bit more than the qualified for the federal poverty level, people can get insurance through K-CHIP for their children. So about 50% of children in the state of Kentucky are covered by Medicaid, and 25% of births are covered by Medicaid in this state. So significant number of at-risk people. And then the last group are the elderly. And as Amber mentioned, there are people that you qualify for Medicare at age 65, but there are still people that are economically challenged, and so they can also be what they're called dual eligibles, so they can have Medicaid and Medicare. And a vast majority of people in nursing homes actually are covered by Medicaid. So once again, the elderly are vulnerable to this because if they are cut, there will be no way to reimburse the nursing homes, which could cause them to have to be discharged, but also the nursing homes may not be viable anymore as well.
Barbara, I want to make a comment about the impact of Medicaid expansion on the healthcare delivery system and ask you if if this is correct.
Sure.
And I don't know what I don't remember the source, but it was my understanding that at University Hospital before the Medicaid expansion, 20% of the patients seen were uninsured. And you know we're basically wouldn't pay for any of their health care. With the expansion of Medicaid, that went down to 5%, which has a significant impact on the ability of this hospital system to provide care. And so my first question is that from your experience being on the faculty and working in there with these uninsured, is that a correct statement?
I do not know the numbers for the hospital. That's probably slightly different. I do know that prior to the Medicaid expansion, about over 50% of the patients that we saw in the outpatient clinic were uninsured. So and that did drop dramatically, and I believe the 5% number is correct. I know that in Kentucky, there are only 5% of people who currently don't have any form of insurance.
Now
So go ahead. In the
go
rural
ahead.
setting, I was going to say in the rural settings, it's even more dramatic. So I think that's one thing we need to keep in mind is that about 82% of the total cost in rural hospitals are covered by Medicaid. So that is those hospitals are really at risk, and the communities are at risk of losing their medical care if Medicaid goes away.
Yeah, that was going to be my follow-up question, and I was going to ask that to both you and Gene, who has been in rural Kentucky all of his surgical career. You know, and maybe I'll let Gene go first, and then Barbara, you've already made a comment, but you could make another one. Gene, how do you see, you know, if they do what they're planning on doing, and I don't know exactly what that would be because I haven't done it yet, but defunding some aspect of Medicaid is going to have a big effect on rural hospitals.
Yes, it will have a profound effect. In Campbellsville, Kentucky, about 73%, and that number may have changed recently, of our patients are Medicare and Medicaid. Now, if you get up in the eastern Kentucky, it's more like 90%. Most of our OB is Medicaid. So if we had a dramatic cut, we would really be in trouble. I hope we would make it, but it would be difficult. Right now, we're doing fairly well. We have a cancer center that takes care of most of the cancer patients in our area, and we're real proud of that, and we're providing good care. But if we get squeezed much more, then it would be very difficult. And it's already hard enough to recruit physicians, and that would make it even more difficult.
Barbara, do you have anything you want to add to that? I know you made some comments before Gene's.
I think that I would just concur with Gene's experience, and based on my research for what is out in the state. Obviously, my personal experience is more in an urban area, but I think even the urban hospitals are going to be negatively affected by this. But gosh, more importantly, what is going to happen to people? And Amber's experience is that will happen again, where people will not be able to get the care that they need, which will have, if not life-threatening, but permanent health consequences. And I just I just can't imagine going back to the way it was, quite frankly. And I practiced for a long time in that setting where there were many uninsured patients, and it was just such a relief to be able to get people the care they needed from the standpoint of the physician.
Yeah, Amber, it's my understanding that applying for Medicaid can be really a nightmare of complexity involving, having to answer a million different questions. Can you give us an idea of, how that works? Is this something you do by phone, online, by mail? If you're an
So,
older person that doesn't have a computer, how do you do this?
so this is where you start running into issues, and I absolutely believe that they need to streamline the system. The caseworkers are lovely. I just want to start off by saying I don't blame them at all. The system is, however, completely broken. You have a few different ways you can apply. You can call online, and they will actually take your information for an initial intake over the phone. But then what they will do is say that, okay, now you have to get all these things together. So, documentation. You can also apply online. But again, I don't personally have internet. I do not have a computer. I have a phone. That's all I have. And if it wasn't for my sister, I wouldn't even have that. So, I'm in a situation where I call them on the phone, I applied, and then they gave me a whole bunch of stuff I had to do. Well, that's fine, but I don't drive. So, I had to get my sister to drive me around to go get all these different things. So, then you have 6 month reviews. So every 6 months, you have to go get more stuff. So, for example, in my most recent review, I had to have a letter from a social worker stating that the social worker knew where I lived, that the social worker knew my financial situation, that, the social worker knows my medical history. Secondly, I had to get a letter from my doctor, and my doctor had to write a letter basically going through all the diagnoses, the heart failure, the post-operative thyroid issues, the hypertension, the whole gamut of things. Then I also had to get a bank statement because I have a little tiny bank account my sister put some money in just to help me out. And then I had to get another letter. This one was from my landlord because I had just gotten a Section 8 apartment. And so my landlord had to sign a letter stating that I was receiving Section 8, that my rent was being paid. So, my sister literally spent days driving me around to go get all this stuff. Not everyone has that sister who can do that. And I mean, what do you do? And then she had to take me to the SNAP office so that they could actually take all the documents and then upload them into the system. So, it's very much based on transportation. It's very much based on having access to technology like printers and things like that. I don't have any of that. It also requires that you have developed relationships with social workers and people outside of, SNAP and Medicaid to actually work with. So it's not the easiest thing to do, and I think that they have access to all of this. I mean, as far as like your tax records and everything else, they have all that. They have access to your bank accounts. So why are they making people jump through all of these hoops? Is my question. I mean, back in the day, I have been told by several workers that back in the day, about 15 years ago, each individual was signed a caseworker, and the caseworker would actually work with you so that things like an address change didn't take 4 or 5 hours. It was really relatively quick, and they could assist you in doing your applications and help you actually filling out the forms and things. That's no longer the case now that they just have these call centers.
Well, now, Amber, did you have a provider before you applied for Medicaid? Uh, And if you did, or if you didn't, how did you find one who was willing to take you on?
I did not have a provider. At the time, I was going without my meds and had become very sick again. When I got to Kentucky from another location, my sister was able to help me actually get a social worker through a disability program that she was familiar with. That person actually assisted me in calling the actual Medicaid application process. So then they helped me navigate that system. And then after that, what happened was Medicaid basically, the office here in town told me that the Fairview Clinic was the place that I would be going to actually meet my provider. And so then I went there and actually met the doctor.
Okay, well, thank you. Barbara,
Yes.
maybe you can help the listeners and maybe help me out a little bit. For as many years as I was in clinical practice, both in private practice and in the faculty, I really never paid much attention to a lot of these various designations, and in doing some research and listening to podcasts in order to ask intelligent questions in this program, I kept running into this quote safety net hospital designation. And I never did look it up. I just thought it would be a good topic to talk about, because I doubt that the listeners have any better idea about a safety net hospital than I do. So if this is not a fair question to you, then we can move on. But I was wondering if you could maybe explain to me and our listeners what is a safety net hospital as opposed to, just a regular hospital like Norton's or U of L, or maybe they're both safety net hospitals.
So I don't know if that designation is still out there, but a safety net hospital traditionally has been the place to go if you're uninsured, and it's kind of like the last resort of the place. And actually in Louisville, U of L was that place for a long time. So I don't know if they still use that designation. In the past, the state would give money to hospitals to offset the uncompensated care for uninsured patients, and that was called DISH money, disproportionate share money. With the expansion of the Medicaid, however, makes sense that you might not need that anymore because so many fewer patients are uninsured, and so I think that money has actually been, if not totally discontinued, at least decreased significantly. So that was one of the ways I think that, for example, U of L Hospital was able to provide the excellent care they always had, is because they received some DISH money, even though a significant portion of their patients were uninsured. And so that's one of the things that's going to really complicate the situation, is because that money is no longer there. And if your patients are not paying, basically, or are not insured, then it's going to make that worse. So I'm not aware that the safety net designation, hospital designation, still is used in that way, but it possibly could be. So,
All right, well, thank you.
Amber, can you give us an idea of what it's like if you're making minimum wage and then you advance to a job where you're making $2 more an hour? What happens to your Medicaid?
Yes, I actually had that experience. I was working as a hotel cleaner in Harrisburg, Pennsylvania for a while, cleaning hotel rooms, and I was making $9 an hour. And of course, at that point, that amount of money, I had Medicaid as well as SNAP. And I was given a wonderful opportunity to actually go to work at the homeless shelter where I had lived for some amount of time. about a year before. And so I jumped at the chance because they were paying $11 an hour. And I thought, oh, this is great. I'll have a little bit extra money in my pocket. I can maybe do a little bit more saving to try to get ahead. And I took the job without really thinking that, this was going to basically send me back into homelessness. Um, but I took the position and loved my job. But within about 2 months, I received a letter from Medicaid saying, oh, you now make too much money. So they cut my Medicaid off. And, as I mentioned previously, and maybe one of the doctors would do a better job than I would describing what happens to a person that has no thyroid. But I ended up at that point unable to afford to get my medications anymore. And so I ended up getting sicker and sicker, basically experiencing hypothyroidism, which ultimately, from what I've been told, hasn't happened yet, thank God. You end up in a coma. But I ended up very, very sick, had to quit the job, ended up homeless. Again, it was disastrous. It was absolutely disastrous. I
Barbara,
had no idea that just getting a $2 raise
yeah, thank you.
would do
I
that.
want to ask both of you if you could give us your thoughts about this prospect of work requirements to be on Medicaid. It's my understanding that the legislative geniuses in different states are considering adding those kind of requirements in order to justify changing the amount of funding to Medicaid so they can justify extending the tax cuts for the rich. So, Barbara, why don't we let you go first, and then Amber, you can follow it with your thoughts about
Mhm.
how work requirement. I mean, I'm not sure what that means, how it works, what you have to do, how do you prove you're doing it. Now, Barbara, do you want to start, and then we'll let Amber have a go at it.
Sure. So this idea has floated around quite a while. In fact, if you remember, Matt Bevin, when he was governor, tried to institute that in Kentucky. Um, the truth of the matter is that most of the people on Medicaid either work or are disabled or care for minor children or elderly parents or have some other condition that keeps them from working. So the concept that people on Medicaid are not working is not true. That is also something that I saw personally in my patients who I took care of many Medicaid patients, many of whom actually worked two jobs. And remember earlier in the program, I mentioned the amount of money if someone worked full time as in a minimum wage job, they would clearly be below the level to be able to qualify for Medicaid. So um, I um, I think that this is just trying to create further barriers for people. Amber indicated how difficult it is to actually get Medicaid from that standpoint anyway. But also, this is another barrier to make it harder for people to be able to document that they've worked and the other thing they've said is not just even gainfully employed, but volunteering. The idea again is, and I use this term, it makes me cringe to say it, but they want people to have skin in the game with it. Well, I say people have skin in the game, they have their health. And they are trying to stay healthy, which is better for our state too. If we have a healthy workforce, and then also our people are living longer, it's better for our state. So personally, I think that this is going to create a bureaucratic nightmare of trying to document that people are complying with these rules. And most of the people, in my experience, are anyway. So, or have a very legitimate reason why they can't work.
Amber, your thoughts?
Um, I, I would basically agree. Most people that have Medicaid are working if they're capable. there comes a point there where you can't anymore. And, you know, a lot of times it's just absolute necessity that you have to work, because otherwise, where do you live? You don't have rent money. You don't have money for food. Um, in my own situation, my health had been so compromised after years of this going back and forth, taking meds, not taking meds every 3 days just to portion them out, that it has created, you know, basically the condition I'm in now, which prevents me from working. But just so you know, if you do not apply to work, they will cut you unless you can get proof that your medical condition is such that you can no longer work. I actually have to, again, go to my doctor and get letters, and also go to my social worker through the disability group here in town to actually get letters to, you know, basically keep them from dropping me. So that is the problem you're faced with.
I actually looked this up, and during the last Trump administration, where there was so much emphasis on work in order to get Medicaid, the only state that really succeeded in doing this was Arkansas, and the administrative cost was phenomenal, and to the point that it probably didn't save that much money because of all the administrative costs. You can imagine, you got a Medicaid patient and you got to keep up with them and make sure they're working and they show up for work. And how do you do that? And then what do you do if the person stops working, et cetera, et cetera? Let me ask another question. What is this Medicaid cut going to do to seniors who are on Medicaid and Medicare? And particularly, what's it going to do to nursing homes?
Well, I think I mentioned earlier that the possibility of nursing homes closing is quite significant because so many of the residents, the cost is covered by Medicaid. And so it could cause seniors to have to be discharged who may not have a place to go. And you know, we have not done a very good job of providing support for family and other caregivers to keep people in their homes, if that's a choice. So, and then if there is not money for it, the nursing homes themselves might have to close. So I think that's a significant risk of in our state in particular, because so many people, so many nursing homes are really supported by Medicaid dollars.
I go down to a rehab hospital in Greensburg. Jane Todd Crawford. Jane Todd Crawford was the first person to ever have an intra-abdominal surgery done by Ephraim McDowell in 1810. And the hospital is named after her because she was living in Greene County at the time she had her surgery. Anyway, I go down once a month and change trachs. And so I have patients down there who there's no place else they could go. They are on Medicare and Medicaid, and they're on ventilators, and they're on ventilators 24/7. And I don't know what would happen to those patients.
Well, I have.
Can I make?
Go ahead.
I just want to piggyback on that comment about people that are seniors. I was homeless. I knew several homeless women while I was homeless. There is nothing scarier and more dangerous than being a vulnerable elderly woman on the streets. If these people have any heart at all, this is the worst thing that they could do to these people. If they have nowhere to go, I mean, do you think that it's survivable for a 70-year-old woman on the streets? I will tell you it's not.
Well, I would very much support that statement, and then add to that that the motivation for doing this is to extend tax cuts that benefit the top 5% of the
Yeah, it's
people
unconscionable.
in this country. I mean, just think about that. Well, let me move on to something else. Gene mentioned this, and I admit that during my educational reading and podcast listening, in order to ask intelligent questions during this program, I ran into this situation where they are people who have both Medicare and Medicaid. And it was an interesting set of circumstances. Barbara, I suspect this is probably a better question to you than to Amber, but maybe I'll let you start first and see if Amber wants to add something to it. But could you explain to our listeners, because I wasn't aware of this before I was, learned about it in preparation for this program, and I doubt that most of our listeners, at least some of them anyway, will not be aware that there is a group of people out here in the country who have Medicare and Medicaid. So could you kind of give us an example of how one would get into a situation like that?
Sure, these are what we call dual eligible people. So Medicare is for people over 65 or people who are on disability and have been disabled for at least 2 years consecutively, so they can qualify for Medicare at a younger age. Um, just because you're 65 doesn't mean that you aren't still poor if your life has been that way for a while. So those people may be on Medicaid prior to turning 65. They end up getting Medicare, which gives them another layer of insurance, but their income still qualifies them to be on Medicaid. And so those people are dually insured. And then I think that one thing that we sometimes forget with Medicare, I know this program is not geared towards that, but Medicare A that you automatically get when you're 65 only covers your hospitalizations, and it only covers 80% of that. So you still are responsible for 20% of your bill, which is, one day in the hospital, that's like a lot of money. And then many patients who are economically challenged cannot afford to purchase Medicare B, which covers outpatient visits. So for those people, Medicaid is a lifeline to having outpatient care. And otherwise they end up having to go to the hospital for their care, can't get follow-up as an outpatient, and then they keep getting sicker and keep going to the hospital. It's actually a much more expensive proposition for the total healthcare system to have people not be taken well care of as an outpatient. But that's the dual eligible, where they have both Medicare and Medicaid.
Amber, any comments?
What she said is correct, that it actually ends up being far more expensive because when you're in a situation like I was, well, you get to the point where you're so bad, you end up in the hospital, which is far more expensive for you to be there for a day or two than it would have been if you had just been able to go into a doctor and they could have prescribed your medications and you got your medications. But, if you can't get that, your only choice is to wait until you deteriorate to the point where you have no choice but to go to the ER.
Yeah, and again, I'm going to make a comment that I've made already 2 or 3 times. When you think about it, the economic geniuses in the legislature, the national legislature of this country, are considering defunding all or part of Medicaid in order to find some financial justification for extending the first Trump administration tax cuts that benefit the top 5% of the country, and leaving the ones that are, if they lose Medicaid coverage, the cost of health care increases, because instead of taking care of these problems and having these people taking their medications, they get worse. I mean, it's an economic nightmare, aside from being a moral nightmare.
Yes, it's a terrible problem. I would like to raise this question. Uh, what can we and our listeners do about the current situation to try to prevent this preliminary bill from passing Congress? What can we do? Barbara, what do you think we can do?
Well, I have to say that obviously in Kentucky, I feel a little not hopeless, but our legislators don't seem to be paying attention to this. But I think what we can do is continue to contact our legislators and demand that they reconsider this bill. They seem to be responding to the public outcry, and the public is crying out about this because of all the potential downfall of not having insurance. I mean, I personally believe that you judge the soul of your country by how you treat the people who are most marginalized. And if we do this to Medicaid recipients, I think that says that we're just basically mean as a country. And so I think that's my personal opinion, but I think, and that's the moral aspect, but I think all we can do is continue to let our legislators know that we do not support this, that we're unhappy with it. I mean, hopefully in the midterm elections, we can flip some of these seats to, but that seems too far off. It seems like we need to do something more immediate. And so I think, I personally have been protesting. I have been calling my legislators and also sending them emails kind of on a daily basis. So I think that's the only thing I can know that we can do at this point. So.
Well, that's wonderful that you're doing that. I think we all should be doing that, sending them emails and calling. The most important thing if you're in Congress is getting reelected. And it's pretty obvious in some of the recent things that happened, particularly with the acceptance of Robert Kennedy as in charge of the health in the United States. One of the committees was chairman by a physician from Louisiana, and he finally caved in because he's going to has to go through an election next year. And he was more concerned about getting reelected than practicing good public health. There's one other thing that came to mind for me is there are 3 special elections coming up, 2 in the 1st of April in Florida, and I'm not sure when the other one is. And if we could swing those elections, then we may be able to stop some of the craziness that's going on. The only thing we could do is support those candidates, probably by a donation, and then there's a Senate election that's coming up too, and I think it's in Ohio. But if we could just think about that, and maybe a small donation may make a difference.
What I don't understand about the rural population of this country, just using Kentucky as an example, we have a supermajority of Republicans in the House and in the Senate, and the people living in rural Kentucky are the most vulnerable from the standpoint of their economic and health circumstances, but they put people in office who pass laws that are basically not benefit the rural public in the state from an economic and health standpoint. Gene and I have talked about this. For the life of me, I don't understand it.
Well, let me just make a comment about that. I think the reason is that it's an emotional issue rather than a factual issue. And the emotions are so strong that people are voting in the way they do.
Now, emotionally, are you talking about guns and abortion and
Yeah, I'm
religion?
talking about the Second Amendment, guns, abortion, wokeism, creating an enemy in the people who are migrants. You know, it's much easier to motivate a group of people into one cause and to get them going together by creating an enemy than it is to creating something good.
The Nazis did that very effectively in Germany in the 1930s.
Yes, if any of you is interested, there's a fantastic article last month in the Atlantic magazine about how Hitler overturned the democracy in 53 days. I would strongly recommend you read that.
Let me ask both of you, Barbara and Amber, to make some comments or share your thoughts about nursing home issues. I always get a little confused. We did a program on nursing homes a while back, and in the investigation before the program, I learned that almost 70% of nursing homes in this country are owned by private equity companies. Their goal is not to provide care. They get in there and, quote, improve efficiency, unquote, which basically means they decrease the staff available to take care of the recipients in the nursing homes. They often will sell the real estate that the nursing home is in, use that as profit for their investors and executives, and sell a nursing home in 4 or 5 years and move on to something else. And I guess where I'm not sure how that works with these nursing homes basically being mostly supplied or funded by patients with Medicaid. I don't know if this is a fair question, but Barbara, do you want to share your thoughts about that? And then Amber will ask you for the same.
Well, unfortunately, private equity has entered the realm of medicine dramatically, and it's not just in nursing homes, it's across the board in other hospitals and
Yes,
practices.
yes,
And
absolutely.
so, and the practice that you mentioned is exactly what goes on. They, in order to cost cut, does this sound a little Doge-ish or something? Here, we're going to cut costs by firing people, so it sounds like Doge for sure. They will cut staffing and basically try to take the profits out and sell it. And so it's all about the money and not about patient care. So that happens in the nursing homes. It's also happened in emergency departments I'm aware of, where they've purchased the emergency department from the hospitals, anesthesia practices, you kind of on down the line. So that I personally feel that private equity is a huge issue in medicine and should be disallowed. Medicine should not be a money-making entity. It should be, healthcare, take care of patients, and try to keep them healthy, as opposed to kind of going in and robbing take benefit of whatever entity you're purchasing, and then moving on to the next one. So it's definitely a problem in the nursing homes.
I absolutely agree. And I guess the basis of this is the fundamental issue that exists in this country, that we do not have a health care system that is focused on providing good health care to all of our citizens. We have a health care industry that is focused on extracting profit from every healthcare activity. Amber, you have any thoughts about the nursing home issues?
Yes, actually, I do. I think that the most important thing is for people to try to stay at home, although it seems that there's a push now to get people out of their homes as quickly as possible and into the nursing homes because it is a for-profit activity at this point. And I just feel that it's really unconscionable that we have turned healthcare into a for-profit industry. Just like prisons, when you put profit into it, I think the morality of the whole thing just kind of, goes down the toilet. So that's pretty much all I have to say.
Okay, well, we're getting down to the end here. Gene, you want to make any last-minute question or comments? And then I was going to ask Barbara and Amber if they had a final comment, and then we'll let Paul take us out.
Let me make a comment about nursing homes. I just didn't realize this, even as a physician until about 2.5 years ago, all the nursing homes in my county and the surrounding counties except one, all the nursing homes are owned by private equity. And they do not tell people that who owns them. They can change hands and nobody realizes what's going on. And the majority of people in those counties don't really know who owns them.
Barbara, any last-minute comments?
First of all, I just really appreciate you highlighting this issue. It's a huge one, and I mean the long-term actual fix to all of this is to have a single-payer health care. But in the interim, we need to save Medicaid, and I not only believe that from the viability of the healthcare system, but more importantly for patients, and I think, to be quite clear, people will die. They will die if they can't get health care, and that is just morally unconscionable to me.
Yeah, we absolutely agree with that. That's why we're here. Amber, last-minute comments, and we're going to turn this over to Paul.
Yeah, just that this is, as she said, a life or death issue. I don't think people realize that every single one of us in this country, and including those rich people that you keep referring to, realize that it takes one healthcare catastrophe to put you in the poorhouse. One.
Yeah.
That's
Well,
correct.
listen, I want to thank you both. This probably has been a very interesting program. And Paul, it's all yours.
Okay, I want to thank the listeners for tuning in today, and please come back again for Single Payer Radio. That's all we have. Have a wonderful day.